Welcome to EASL Studio, your weekly hepatology broadcast news. In this episode, we want to discuss rare liver tumors. These are small numbers, perhaps small numbers, but big questions and challenges. So my name is Thomas Berg. I'm a hepatologist from University of Leipzig, but also co-producer of the EASL Studio. And the reason why we are here is that also EASL published a position paper really dedicated to these rare liver tumors. And this is what we want to discuss with two experts that were part of the panel, of the writing panel of this position paper, or you may also call it a guideline. So it's my big pleasure to introduce our esteemed experts. First of all, Professor Henning Wege. He's had two affiliations. One is Hamburg University Hospital, and he's also chief of the liver cancer and gastroenterology cancer section and clinic in Esslingen. And a big pleasure also to introduce Ruben, Professor Ruben de Kleine. He is a surgeon and from the Department of Surgery, the section of hepatobiliary surgery and liver transplantation at the University Center in Groningen. And both experts are also part and centers of the European reference networks dedicated to rare liver diseases. So they have a great expertise also in this setting. I mentioned these can be rare diseases and the guideline covers several of these rare tumors, but we decided also in the interest of time to mainly address three different rare primary liver tumors. The one is the combined hepatocellular and cholangiocarcinoma, perhaps the one we see most often, but this we will discuss in a minute. Then the fibrolamellar carcinoma, and I know perhaps all of you will diagnose once these tumors, and then it's always a big challenge what to do with them. And as the last part, we want to discuss about the epithelioid haemangioendothelioma. So first of all, a warm welcome to you, Ruben, and to you, Henning. You're doing well?
Thank you.
Yes, I'm doing fine. Thank you for the introduction.
Yeah. How was the experience, perhaps to start with a quite open question, when writing these rare primary liver tumor guidelines or guidance? Were there very big challenges? How was the team? What were your expectations? And do you feel the mission is accomplished with what you expected to do?
Well, the biggest hurdle was the lack of evidence. So it's actually just a position paper with expert opinions, with recommendations. It's not a clinical practice guideline based on phase 3 studies, for example, for the systemic treatment. But that's also the fun in putting together such a paper, because you have experts from all different countries in Europe. We had experts from Spain and UK, Belgium, Germany, France. And you also have experts from different specialties. So you have a surgeon like Ruben, you have oncologists, you have radiologists, and they all have a different way of handling these rare cases. And I think it was a successful achievement to bring the different opinions together in let's say, a unified recommendation for the different topics we discussed.
And I think by reading the position paper, surgery, of course, plays a really major role in treating these patients, especially, of course, when diagnosed early. So, Ruben, what was your experience and what is your personal experience with these tumors in your center?
Yeah, surgery is the way to go if you want to have a curative intent, of course. So you need each other to assess the diagnosis and also to assess the best therapy. And luckily, surgery is still the cornerstone of curative treatment. When I was invited to participate into into the group. I looked up all the names, and I said, okay, I want to be in this group, because even though the evidence is very limited, the group is very strong and very diverse. So that's why I was happily contributing. Also, I'm not a professor, I'm just a simple surgeon. So, but surgery is very important in those rare tumors, especially if you want to have a curative intent and a free margin. For a lot of these malignancies, free margin is something to go for. And if you cannot achieve a free margin in a resection, I think the other therapies should be evaluated, whether it's minimal invasive therapy and as a palliative setting, or a curative intent setting as a liver transplantation.
Yeah.
So you need the MDT for that.
Yeah, the multidisciplinary team, you mean, with MTD?
Yes.
Yeah. So perhaps we can start with the combined HCC and CCA, and perhaps to start with, it's a rare primary liver tumor, perhaps yes, but perhaps less rare as compared to the others. Correct, Henning? Or how
Yes.
often do you see these tumors?
Well, we looked at the data, and it's reported in 1% of all primary liver cancers, this rare entity, but I think it's heavily underdiagnosed, because especially in patients we give systemic therapy, most of the time the diagnosis relies on just one biopsy. But if it's a large nodule in the liver, and the definition for this combined HCC-CCA is that you have both entities in one nodule. And if it's a large nodule, you actually need more than one biopsy to establish the diagnosis. So I think in the patients receiving systemic therapy, it's heavily underdiagnosed.
Yeah, Ruben, would you agree? And I think there were recent data presented at the EASL Liver Cancer Summit, and I was really surprised that lesions that had typical feature for hepatocellular carcinoma with a wash-in, wash-out, but it was a French study, and they did the biopsies in all of them, and I think they ended up with a very high number, 20% or so, where it was actually a combined tumor. Do you have similar experience, or how do you approach and diagnose?
Yeah, tissue is the issue, and especially sampling error can be dominant. If you have necrosis, it can be even more difficult. So I don't envy the radiologists in taking the biopsy. We try to select the vital areas and go through normal tissue, and then image and sample the vital area. So that's very important also. I think the biggest difference is that the CCA component comes from the bile duct, and the HCC component comes from the hepatocellular cells itself. So sometimes you can select a little bit of the area where there's bile duct dilatation or not. So that can influence also the area where you select your biopsy. But definitely...
Sorry to interrupt you. You can see this by CT scan, or do you need an MRI to really find these?
Well, on the normal CT scan, you can see bile duct dilatation also in the segmental branch. And I think that is something that is more prominent in the CCA component, I think. Yeah. And if you want to go for that area, and especially if you see a vital area, not a necrosis area, that's the area you want to go. For me as a surgeon, it's very important that you think about your biopsy before you select your therapy. If you do a biopsy directly in the tumor, you might limit the opportunities. So go through the section that will be taken out in surgery, if it is an option. And if you are in doubt, please talk to your surgeon about this.
Yeah. And perhaps...
I think, if I may add, contrast ultrasound is the best way to do this biopsy. And the suspicion should be high in patients with imaging features of HCC or CCA that do not fit to the biomarker, for example. You have high AFP, but it looks like CCA. We all know there's CCA with high AFP, but it could be a combined tumor, and then biopsy is worthwhile. If you cannot do resection up front, and I think that's also something we should discuss, whether we skip the biopsy and go to resection.
Yeah, exactly. And I think the one point I want to make, because you made it so high, even a 5,000 AFP does not exclude a combined
No.
HCC-CCA. I think this is a very important message, and I fully agree. But people may argue if it's a resectable or even a tumor that can be, with a curative intent, be treated by a local ablation therapy, do we then really need a biopsy? Does it matter? Has it consequences? What do you think, Ruben?
Yeah, I think the centers that do a lot of local regional ablative therapy, whether it's microwave ablation or IRE, they know the value of the biopsy before, so they use a supportive needle to take a biopsy and then burn, because if you ablate these tumors, you have no tissue left.
So in the same session, you mean, right?
It's the same session.
Okay.
It's the same session. So I don't think that excludes the sequentialness. It gives you the tissue and it gives you the follow-up regimen also, irrespective of the elevation of CA 19.9 or AFP.
Yeah. And if the tumor is resectable, but you do not know exactly whether it's a combined or a CCA or an HCC, but you have excluded a metastasis, would you go directly for surgery because then you have the histology?
Yes. Yes, of course. As long as the future remnant liver is well enough and resection is an option for this patient, so the patient is fit enough to undergo these major surgeries. These tumors present late, so the amount of tissue that you have to take out is usually a lot. And we have some tricks for that, of course. We can do a portal vein embolization or even a double vein embolization, and even a double vein embolization, and look for instance, embolization of segment 4 to prepare the patient for an extended hemiapopectomy. So these are options that you need in your regimen, in your treatment regimen for these patients.
Yeah, and Henning, I realized that you have the same approach. If resectable, you do not do. Right?
Yeah, especially liver cirrhosis is not as prevalent as in patients with HCC in this rare diagnosis. So if resection is possible, we definitely discuss in the multidisciplinary tumor board, and then we know for sure what it is because we have all the tissue. Of course, the suspicion that this is a primary liver cancer without extrahepatic metastasis has to be high. And if resection is not possible, we carefully plan biopsy. If it's not a clear HCC or clear CCA, because it has consequences for further downstream therapies.
Yeah. I think what becomes also clear from the position paper that in a way, if you have a single curative tumor or that is with a curative intent can be treated, that perhaps the management of these tumors as a first-line treatment is not so different from a classical HCC, right? But then it comes to the question perhaps of transplantation and the question of adjuvant therapy. Perhaps we can start first with adjuvant therapy. It's not established for HCC, it's established for CCA in most centers with capecitabine. But how do you deal with the combined HCC-CCA? Do you use adjuvant therapy in this setting after curative treatments? Perhaps, I don't know. Would you like to start, Henning, and then Ruben in your center?
Well, I think more interesting is actually the neoadjuvant therapy, also not established.
There are a lot of cultural differences also in the adjuvant therapy. In the Netherlands, we are very reluctant to give adjuvant therapy, even after the BILCAP trial and some other trials that have been done. And I know
we are currently evaluating adjuvant therapy in the Actica trial, international trial, and probably at the end of this year we have the first data. But coming back to the neoadjuvant therapy, I think if you have a combined tumor, not resectable, but potentially resectable with some radiologic response, it's really worthwhile after chemotherapy, if you have radiologic response, to discuss this patient again in the multidisciplinary tumor board. We do the same for cholangiocarcinoma, and actually we follow pretty much the path that we normally that we have established for cholangiocarcinoma.
Yeah.
It
So
becomes
perhaps,
especially difficult if you have a possible enlarged lymph nodes in the ligament as a sign of a prognostic unfavorable characteristics. So if you deem those patients irresectable based on lymph node status, and you have an impressive response on neoadjuvant chemotherapy, what do? We tend to favor this, but it is a debate, and it depends on the condition of the patient, of course.
Yeah, this is an interesting point. Do you feel that enlarged lymph nodes, regional ones, in the hilum of the liver are an exclusion criteria for liver resection?
Yeah, it depends on how you look at it. So we try to sample these lymph nodes via endo-echo to get more data. Currently, we have an ongoing study for this to evaluate the value of this sampling, but also the prognostic characteristics. So we know from the transplant data for cholangiocarcinoma that this is a very poor prognosis for cholangiocarcinoma. So if the intrahepatic part already gives metastasis, which is even further away, is this similar, or is this even worse? Or so this is an ongoing debate at our multidisciplinary meeting. But there is value in neoadjuvant chemotherapy and impressive response.
Yeah, I think there's a kind of an agreement. And perhaps coming back to the lymph nodes, because this is always in the tumor boards an issue, right? And how you can judge just from imaging whether enlarged lymph nodes are infiltrated by the cancer or not. And I'm aware, perhaps you can comment on this, on studies, that in 50% you are wrong, that lymph nodes that look unremarkable are infiltrated and the other way around. Perhaps as a minor point, but would you like to comment on this?
Yeah, I think the diffusion weighted images for the MRI is very important in this. I think if you have an enlarged lymph node, it can be malignant, but if you have an enlarged lymph node with added diffusion weighted images, I think you should consider this a positive lymph node.
Yeah. Henning?
Well, currently we would probably not exclude any patient from resection just because there are lymph nodes in the liver hilum.
Yeah. Okay, I think perhaps a last question and a brief statement. Is there a role of transplant in these combined tumors? They are very restrictive, of course, for cholangio. And how do you deal with these combined? Do you have an approach in your centers or any recommendation for our audience?
Yeah, so not if they are resectable. So question one is first, are they resectable? That's the easy answer, I think. What do you do if they are not resectable? I think then the question becomes if there is an underlying liver disease, if it's very young. So we tend to have a more liberal setting for very young patients under 30. But then the prognosis is very difficult to ascertain. So these are very rare patients, usually not the mixed type patients that we discussed before. But that is a different setting, yes.
Okay. Any comments on this from your side, Henning?
Well, in Germany, they don't get priority on the transplant list. So it's not easy to get a liver for these patients. But it is a very careful evaluation by the transplant committee whether there's a contraindication. And yeah, I think during the waiting time, we will see the tumor biology. And then if the patient progresses, it's probably not a candidate for liver transplantation.
Yeah, but if I get it right from your answers, it's only in those with liver cirrhosis, correct? Being unresectable or
right. No, resection, I totally agree with Ruben, is the first line curative therapy.
Yeah. Is there anything what we missed about these combined tumors, or can we move
forward?
I
would add that because the CCA component is part of the tumor, in comparison to HCC, it's good if you do a molecular pathology analysis early in the systemic treatment, because there are driver mutations, the same driver mutations we have for CCA. And since we have established drugs for CCA driver mutations, we can use the same drugs for this combined tumors.
Okay, yeah, that's a very important point. And in terms of systemic treatment, if it's really advanced, unresectable, metastasis present, what is your recommendation, or what is the recommendation of the position paper to go for? Is it a typical CCA systemic treatment regimen?
That's what, well, there's no study, of course, and these patients were excluded from all phase 3 studies in CCA and HCC. But I think in the discussion was pretty clear that most centers tend to use chemotherapy for CCA, platinum-based therapy, because that's considered the more aggressive part of the tumor.
Together with a PD-1, so an immune.
Yeah, right. Durvalumab, pembrolizumab, gemcitabine, the whole package.
And platinum. Yeah. Well, I think that's the same what you're doing in Groningen, right, Ruben?
Yeah, it's difficult. Yeah, you need a very good medical oncologist for these patients.
Okay. Now, so let's move forward to the fibrolamellar carcinoma, and perhaps, Ruben, the typical clinical situation where you see these tumors, and I know you're a very big center, I think a reference center also for these tumors. What is a typical appearance and picture of these patients?
Yeah, so we're lucky that we are the Dutch reference center, the National Dutch Reference Center for patients under 18. So we know that these are young patients, relatively young patients, and that there are more. The peak of the incidence is around 20 to 30, and there is a category around 4 years and older up. So there is a mixed children and adult group. So yeah, you need the therapy as a surgery to evaluate again, is there a resection possibility, and if not, if it's not resectable, do we have the chance to get this patient to transplant? And in our setting, we tend to be liberal in neoadjuvant chemotherapy, and whether it's a classical HCC or if it's a proven fibrolamellar HCC.
Yeah, and is it correct that it's more often in females than in males?
Yes.
Yeah. And
there's also the suggestion that the females have a better prognosis.
Okay, and it can be misclassified or diagnosed also as a hepatic adenoma or
FNH.
More or less an FNH. So you need a biopsy, right, to do
focal nodular hyperplasia, because it had the same central scar. So, well, that's I think really important for if you treat a lot of patients with liver lesions and nobody knows if it's benign or malignant. If you're not sure that it's FNH, I think it's very important to consider, especially in young patients, that it might be a fibrolamellar hepatocellular carcinoma, and then you need a biopsy to prove it.
Yeah, I think that's a very important point, because I think now the recommendation for FNH is not to follow these patients, and this could be.
But that's only if you know with imaging studies you have the characteristic imaging pattern, and as well, what I do a second imaging study, and I follow the patients at least once to be on the safe side.
Yeah. So if you do a histology, and we mentioned molecular classification, is there any marker that is helpful to diagnose, or perhaps also as a druggable target consequences?
Yeah, there's a fusion. It's a long name. DNA JB1 PRKCA fusion, and well, it also exists in extrahepatic tumors. But if you see this in an intrahepatic tumor, it's a fibrolamellar hepatocellular carcinoma for sure.
And it should be always done, right?
Yeah, it should be always done. And it has consequences for therapy. Well, we don't have the drugs right now. There was a drug trial, unfortunately negative. But I'm involved in a multi-center phase 1 trial here in the southwest of Germany by the Centers of Personalized Medicine in this region. And they have a peptide vaccine against this fusion protein, and it's combined with atezolizumab, so checkpoint inhibitor, to make it more effective. And if the phase 1 is successfully completed, it will be available for treatment in more patients in further studies.
Yeah, I think systemic treatment is perhaps also the question most people are interested, because we are really lacking good data. But I want to come back first perhaps of these curative treatments and the role of surgery. So Ruben, in a situation where you perhaps cannot cure the tumor by resection, but as what is called a debulking or so, does it play a role, especially for fibrolamellar, that you reduce? Because quite often these are very large tumors, that you do even this kind of debulking surgery?
Yeah, so again, there are cultural differences. In our center, we have not done that. We are reluctant to undergo these major kinds of surgeries for just debulking. I know that there are centers that are more liberal in this, but not the team in Groningen. Yeah. So our intent has always been to really stage these patients well with adequate MRI, with T2 sequences, diffusion-weighted images, really have a dedicated radiologist looking at this. So not just a general radiologist, but one who is in the HPB team, and then evaluate if the patient is resectable with margin.
Yeah. Before we come to the different systemic regimens we may use in these rare liver tumors, do you see a role for neoadjuvant or adjuvant therapy in this setting?
Yes. Yes,
What?
there are. Well, as a surgeon, I see a role for this. One is the test of time, and the other one is that we do see a response in these tumors that facilitate the margin towards a resection. And the one thing is that we evaluate those patients after 3 courses of the chemotherapy, complete them up to 6 courses of chemotherapy, and then try to get them into a window of surgery. Unfortunately, the results, especially in male patients, can be bad, but that at least the intent of curative goal is there.
Yeah. And Henning,
can I ask you, we had a hard time in the position paper to recommend systemic therapy. Your oncologists in the Dutch reference center, do they always give the same regimen, or is that based on tumor characteristics?
Well, the question is always what kind of regimen, and there's no uniform answer in this. So if the patient is very young, we have the possibility to talk to the National Pediatric Oncology Group at Utrecht. So for all the patients under 18, it's the care for the Netherlands, the whole of the Netherlands is centralized. And we know that they favor the doxorubicin cisplatin chemotherapy for HCC and possibly also for fibrolamellar also. And we know that these very young patients, they tend to tolerate much higher doses of chemotherapy than the older patients. So they're really aggressive in this. And then you have the adult patients from up to 19 years old. We recently did a transplant for a child child, a 19-year-old, for this, and it is a challenging situation, but she tolerated everything very well with impressive response, either on imaging but also on AFP. So this is valuable for very, very selected patients.
Yeah. So I think
well, there is no current state of the art treatment for this rare disease. So I think we need studies. That's also what we tried to make clear in the position paper. The most data is available for interferon and 5FU based regimens, but I think when we looked at the data, there are promising results for checkpoint inhibitors, and I think at a certain point, I think immune oncology treatment for these patients, if you don't want to do liver transplantation, but that's also debatable for patients who might go for liver transplantation, is something worthwhile to try in these patients.
Yeah.
And I think from a future perspective, there is a role for tumor slices and individualized therapy.
Yeah.
So perform the resection, create the tumor slices, and then sample up to 50 or 60 checkpoint inhibitors or other immunological markers.
Yeah, because I realized also when reading the paper that the percentage of patients with fibrolamellar or the fibrolamellar carcinoma being PD-L1 or PD-1 positive is relatively high, higher than in classical HCC. And also during the EASL Liver Cancer Summit, when it was also discussed, I realized that most centers now are going for an immune checkpoint based, like atezo-bev, perhaps even dual immune check therapy, that this is more like a current standard, and people are not really using any more interferon, was my takeaway from the debate. What do you think, Henning?
Yeah, I think that's a worthwhile approach, especially if we have 2 regimens in HCC approved in Europe for treatment of HCC. That's something you should try, definitely.
And it reminded me also a bit on melanoma, where also interferon played a role. Yeah. And of course, interferon is a kind of an immune therapy, so perhaps that these interferon responsive tumors may also respond well to immune checkpoint inhibitors.
Yes, well, I think we won't have any problems with regulatory authorities if we give these drugs, but it will be interesting maybe to collect all these patients in a registry, for example, to see what the outcome is, because at this moment, these patients have been excluded from the phase 3 trials for HCC.
Yeah, so could you mention these registries that are out there and where you can get in contact with to provide the data and be part of it?
Well, there's an international global fibrolamellar carcinoma registry. I think it's from the Rare Disease Initiative in the United States. And there's an EASL sponsored registry that's currently being prepared and will start hopefully pretty soon to collect patient data.
Okay, thanks a lot. Well, I think we can now move forward to the last tumor we want to discuss. And this is a kind of a special tumor because it's not clearly benign, neither very malignant. And it's called the epithelioid haemangioendothelioma. And Ruben, what kind of tumor is it? And how to differentiate it from the sarcoma, the hemangiosarcoma of the liver, also very rare.
So the tumor itself can be very benign, but it can also be very, very malignant. The spectrum is very wide. And the HE patients are much younger than the angiosarcoma. So the angiosarcoma are 60, 65. And again, the female predominance and the younger age is a clue in setting the diagnosis. So usually between 20 and 40, around 25 is the major group, more females. And if you look at the radiological characteristics, there's more of continuous growth, not so aggressive, not so invasive, more of a protrusion of the liver tissue. But it can be multifocal and it can be bilateral in the liver, and it can also metastasize to other parts of the body, lungs, bone. There are cases out there that have a poor prognosis.
Yeah, and the standard treatment, if resectable, is resection, right?
Yes, yes.
But as you mentioned, quite often it could be bilobar or very large, so that resection is not possible. And then the question arises whether we should go for transplant. And
well, really try to resect first, and really try to get all the tricks that you have in your toolbox as a surgeon to resect those patients. We know that it can have a very indolent growth, and that you can really even ablate afterwards if you have a recurrence or if you have a lesion that you missed. Sometimes there's an outgrowth. If you do a hemiapectomy on the other side, you can really ablate, and we have had patients coming back several times. And also keep in mind is that a transplant, if there are no extrahepatic lesions that are not resectable, that a transplant also after surgery can be an option.
Yeah, and I know that a big issue is really by imaging and without knowing the course and the trajectory of the disease, it can be very difficult by imaging and even by histology to differentiate between the sarcoma and the endothelioma. Is it correct? Or what's your experience here?
Yes, again, these are younger patients, and we consider the sarcoma somewhat of an oncological emergency. If in those patients, I think it's also in the position paper, if you have the suggestion that it is an invasive growth, it's an older patient, and it qualifies more as a sarcoma than an HEC, again, you need a good radiologist for this. We consider this to be a hepatic emergency, and if you deem this patient to be resectable, really try to push your program and push your planning to resect those patients within 2 weeks or 4 weeks at the maximum, because you will miss your opportunity to give a curative window. That said, it can be a poor prognosis anyway.
Yeah.
So if you have intermediate imaging, for instance, a CT scan done, and you believe it is outdated, do an MRI. If it looks for rapid progression, it's more likely to be a sarcoma than an HEE.
Yeah, which can lead to liver failure, as you mentioned, within weeks or days.
Mm-hmm.
So Henning,
if I may add, even in patients since the tumor has sometimes a very benign course, it's not so aggressive, we may consider resection and even liver transplantation in patients with limited extrahepatic spread, if it's stable for a longer time.
Yeah, so what's your approach to this type of tumor in terms of diagnosis and then treatment? Do you have a kind of an algorithm?
Well, the radiology department tells you this it's sometimes pretty clear on imaging studies that it's haemangioendothelioma, and then of course you need a biopsy. There are some tricks that the pathologist might use to find out this is not a sarcoma if he's not entirely sure. And then it's really difficult because you need the test of time basically to find out whether this patient has an aggressive course, and patients with an aggressive course are definitely not good candidates for liver transplantation because the tumor will come back. But if it's a very slow and benign course, sometimes they don't even need systemic treatment. Just watchful waiting might be the best approach to these patients.
And what is your recommended systemic treatment in this context? Was there an agreement on one regimen or?
No, again, no phase 3 studies, case reports, retrospective case series with different kinds of regimens. I mean, if you look at what patients do, then anthracycline is probably what most patients use. So it's a sarcoma regimen, basically.
Yeah.
You would imagine that you would go for a vascular inhibitor.
Yeah, bevacizumab sometimes is used. Yeah, even TKIs, VEGF-directed TKIs have been used.
So perhaps it's really to reach out to centers if you have these
Yeah.
tumors. And again,
But there's hope because there are studies, and the studies have recruited patients, MEK inhibitors, for example, VEGF-directed therapies, and I think we will get some results from these studies, randomized studies. Yeah.
yeah, well,
One more
unfortunately,
other point for this. Sorry.
yeah, sorry, please.
I think if you do the curative intent, you should still do the follow-up. Also, if it is a transplant patient, keep those patients in check. Sometimes there have been cases that you have a intrahepatic recurrence in the graft, and you need to do a follow-up treatment for that.
Yeah.
Well,
and for the clinical situation, the most impressive and most challenging clinical situation was actually a patient we diagnosed a Budd-Chiari syndrome, but in the end, I don't know if you had such cases, Ruben. We did a liver biopsy, everything. We did a TIPS. The patient did not improve, and with progressive liver failure, we went for transplantation. And then the explant showed us that there is a haemangioendothelioma being responsible for the cause for the Budd-Chiari syndrome.
Yeah.
That was challenging.
Well, that's excellent. And unfortunately, I think we need to close this studio episode. So I really want to thank you for an excellent discussion. Perhaps, as always, I think I would like to give you the chance to, if you want to name one major unmet need or next research priority in these rare liver tumors, perhaps Ruben, you first. Is there anything you want to let you know, our audience?
No, I think if you encounter a patient like this, be aware and appreciate that it is a very rare tumor. So really look to your own team if this is the right place to treat those patients. And the best treatment for those patients is to get help and really refer to a major center because it can be very, very tricky to treat it.
Thank you, Ruben. And Henning.
Yeah, help is available, for example, through the ERN Rare Liver Disease Network, and we have the clinical patient management system, so you can find that easily on the internet. You can upload patient cases and discuss with experts to find out, at least for the diagnosis, maybe what the best way is. But then I have to agree, in the end, you need a good liver surgeon, you need a good liver center, you need a transplant center. You have to work together to get the best treatment for these mostly young patients.
Yeah, thanks a lot. And I think you will see here on the screen that there were 2 EASL-supported registries on these primary or rare primary liver tumors. So I think we want to welcome you, all of you, to join. I also want to announce that before the EASL Congress in Amsterdam on 6th of May, there will be an HCC endpoint conference that might be very interesting to define endpoints in liver cancer. And with this, again, I would like to thank all of you listening and watching to this episode, our experts, a big applause. And the next episode will be next week. And it's dedicated to the 40th anniversary of the EASL Journal, our flagship journal, the Journal of Hepatology, with all the editors. I think it will be great fun to listen to them, what they can tell about their experience and the future of this important journal. And don't forget, if you are not part of the EASL family, join the family and become a member, and see you next week. Thanks a lot. Bye-bye.
Thank you.
Bye.